Good afternoon to everybody, and thank you for inviting me for this talk today. So, what I'm going to talk about is about the challenges with rheumatological diseases amidst tropical infections. So, as physicians working in the ward, we all come across this entity very commonly. So, I'll be talking mainly about the relationship between infection and autoimmunity, a very, I would say, much investigated arena, and then about the challenges faced by rheumatologists in practical setting of a tropical country based on a few cases, and what we need to move forward from where we are at the moment. So, like the relationship between infection and autoimmunity is actually considered like there are theories as to like what is the relationship. So there's a very good article, a research article. If you are interested in reading, it's in clinical and experimental immunology by Colini and et al. So they talk about this. There are four mechanisms like molecular mimicry, is the first mechanism that they talk about, and this is what we have traditionally learned about, where the pathogens sometimes express antigens which are like where we also have in the like self antigens which mimic the antigens that are presented on the bacteria, the pathogens. Therefore, like whatever the now once the antigen presenting cells, the dendritic cells have taken these up and then presented to our immune system through the T helper and the T cytotoxic cells, T helper cells presenting them to the B cells, they identify this as a foreign antigen, our own cells as well. Because the pathogen is stimulating this whole process. The pathogen presents antigens, and we have like not 100%, but somewhat similar epitopes in that antigen as self antigens, and therefore whatever the immune response that is triggered is now acting not against just the antigen but against our own cells as well. So this is the oldest sort of explained mechanisms as to how autoimmunity develops. However, like over time, we have realized this is not the only mechanism. Like not everything can be explained by the same mechanism. So we have moved forward, and this is the second mechanism that has been put forth. It's called epitope spreading. So what happens there is like consider supposedly there are pathogens attacking our own cells, and like during the process of the infection, the pathogen attacks the body cells, and the body cell that is damaged is releasing self antigens, which through complicated mechanisms that's not supposed to be antigenic, but there are certain epitopes that may be antigenic, and they are like stimulating the immune system. And this has a kind of a domino effect because it keeps on releasing more antigens from more cells that are damaged. So it's a sort of a never ending process. So this is what is known as epitope spreading. And the third mechanism is called bystand activation. So bystand activation happens mainly through the T cytotoxic cells, where like through now the pathogen again activates the antigen presenting cells, which like triggers the immune response. And through this, the cytotoxic T cells go and induce self-destruction of the tissue. And in addition to that, there is some antibody-mediated response as well, but this is all damage as bystanders because our cells are there as bystanders. They are not meant to be like damaged, but they're damaged in the process of the normal immune response. Like you can understand this as like somebody wants to kill a terrorist, but instead of a sniper, they take on a like a rocket launch or something. So everything in the vicinity is also damaged at the same time. So it's not precise enough. So this is called bystand activation. And the fourth response is called cryptic antigens. So this is like what is supposedly happening. Again, now our body is supposed to have self-tolerance. Through training of the T cells, through numerous processes, we are supposed to have self-tolerance. So self-tolerance happens because the T cells at one stage of their development, they are presented with our own antigens and taught, okay, these are self-antigens, do not act against them. However, there are certain parts of a given protein that are probably not exposed. So only one epitope of a given antigen is probably exposed. So like at one point, now due to differential proteolytic enzyme activity during an infection, they say sometimes these 50 epitopes may be exposed to the T cells, and therefore that can trigger an immune response. Like so, this is again something like this molecular mimicry as well, but it's different because these are like our self antigens which are not mimicking the pathogen antigens. However, our immune system has not seen this before. because they are cryptic and like were not differentially expressed before. So these are the sort of the mechanisms, but like the end point is autoimmunity and infection are probably very closely related. That is the bottom line. So many theories as to like why this is happening. So not all the not all the autoimmune diseases can probably be explained by these mechanisms, like the relationship between infection and autoimmunity. However, these are probably the mechanisms. So now moving on to the main topic for the day, like what is the relationship between tropical infections and rheumatological diseases, the challenges. So as I like talked about in this course, the possible causation, like the relationship between infection and autoimmunity, probably there's an element of causation. We see this like day in and day out during our clinical practice. We see this all the time. And then about disease mimics, about delaying in the diagnosis, and difficulties with immunosuppression. So this is these are mainly the challenges that we are facing in day-to-day practice. About causation, now you see like two photographs. One of them, I'm pretty sure you all know, he's Henry VIII. So what does Henry VIII has to do with rheumatology is that he has gout. So he's a very well-known royal figure who was suffering from gout. Even towards the end of his life, it says that he was like suffering very badly from it. And the one that you're seeing on the bottom picture is a patient with rheumatoid arthritis. So the royals versus paupers. So gout was actually initially described among very affluent people, like kings and royals, because who got it were people who had a lot of meat to eat and a lot of beer to drink. So those were the affluent people, not the poor. But rheumatoid arthritis was undiagnosed, undetected for a long time because people thought that that was also a form of gout. Because doctors those days treated whomever who could pay them. Nobody did charity, so who could pay them, they treated. And who could pay doctors at the charges that they were charging at the time were people who had money. So royals and like affluent families. So therefore, even when they saw rheumatoid arthritis for the first time, they thought, okay, this may be another form of gout. So it wasn't until about 1800s where they realized this is a separate disease entity. And where it was described was actually in the slums of Paris at one time. So the people who were afflicted with rheumatoid arthritis are completely different. They were the poor people living in the slums. So why was it more common among such people? Probably because of the high infection burden. That is what we can like surmise from that. So this is the historical aspect, the first description of rheumatoid arthritis versus the first description of gout. And the observational evidence, what we see is that our patients have much more severe disease phenotypes, not just of rheumatoid, but of lupus as well. So this is not just a delay in the diagnosis or the treatment, because we see so many patients for the first time presenting with neurolupus for the first time, just with 3 months of history, even digging through the history. Only 3 months, 2 months of symptoms, and then they come with organ involvement. This we do not see in patients like Caucasian Western patients. We do not see this pattern. So to show that it is not our fault only, so we launched this study, which is a 14-center island-wide study, and the initial results are already out. And we see more renal and endogen involvement, like hematological and mucocutaneous disease is much more severe. So we have shown this, and we are going to present our first abstract next week at the EULA conference. So the epigenetics, is that what is to blame? Is that what is driving this more severe phenotype? We don't know, because there is definitely a genetic factor. We cannot deny that. So for many rheumatological conditions, it's being described there are different HLA genes that are associated. So there is a genetic component. However, just because you have the genes does not mean that you are going to express the disease. So this is where these epigenetic studies are concentrating on. What makes the genes express and what makes them go into hibernation. So probably now infection is a number one like factor there. So we believe like maybe in the tropics and subtropics we are having more severe disease phenotype and more incidence. Perhaps one of the reasons is this. So all these pictures are some of my patients, different patients with the same disease. And you can see that the severity of involvement that we have here. You go on the internet, you can't find like pictures of this severity. It's difficult to find. So these are all patients with lupus. The first picture shows a patient with hemorrhagic mucositis due to SLE. And the second one is a subacute cutaneous lupus, and this patient presented with more than 20% involvement of the body surface area, which is very severe. And this patient mainly mucocutaneous, severe mucocutaneous disease, and like she had only a handful of hairs when she came in. All three patients needed cyclophosphamide, which is like one of the most potent medications that we use in the treatment. And then other examples of causation, viral infections and inflammatory arthritis like chikungunya, dengue, and COVID-19, we like have clearly seen cases where the infections precede the onset of the inflammatory arthritis. And persistent inflammatory arthritis following rickettsial infection. So during the acute stage of rickettsial infection, they present sometimes with an inflammatory type polyarthritis, which is indistinguishable from early rheumatoid arthritis. It's very difficult to distinguish, but if you examine carefully, expose the chest and the abdomen and then the legs, you will see the rickettsial rash. So it's an infectious arthritis. It happens during the infection. It's not autoimmune. However, some of these people, even after the resolution of the infection, they go on to have persistent arthritis, which is very difficult to manage. So moving on to the next challenge. So what we were discussing about was causation, like tropical diseases causing the inflammatory arthritis. Next about the disease mimics. This leads to considerable delay in diagnosis. So this is one of the challenges that we are facing very frequently. So the first case, the board team might know about this patient. This was a 19-year-old previously healthy boy from Tabuttegama who presented with fever for 1 month and altered behavior for 1 week duration. And he started having seizures while in the ward. So very refractory seizures and like one seizure different to the next one. And it was at one point, it was like almost like status epilepticus. So the problem was he had fever for 1 month. So like coming with acute febrile illness. And then like he was from a farming family from near Anuradhapura, and there was significant exposure to wooded land as well as for saprophytic organisms. So in such a patient, infectious differential diagnosis is very wide when they present with this presentation. So we considered all this, like for this chronic bacterial meningitis, melioidosis, malaria, as well as leishmaniasis, because he had some very odd cutaneous lesions on the legs only. So we were thinking, could this be leishmaniasis or rickettsial infection? So all of this was in the differential. But the problem was time was running out. By the time, like within 2 days after admission, he started developing seizures. So we did not have a lot of time to like go into these infections in detail. So after about 3 days, we noted that there was bleeding from the mouth. So the first picture I showed you was from actually that patient. So he had hemorrhagic mucositis. And on the full blood count, there was pancytopenia, but that does not really exclude an infection because most infections, if they infiltrate in the bone marrow, are going to cause pancytopenia, which is a problem. And to make matters worse, his inflammatory markers were not typical of SL. His ESI was only 29 and the CRP was less than 6. CRP as expected, but we would have expected a ESI which was much higher than this. And we imaged with what we had, CT and the non-contrast and then later the CECT brain. Later, like much later, once we had the diagnosis, we got the MRI brain, which again came back only as perimetrically leukomalacia, nothing more. And the LP was negative. And on clinical grounds, because the patient was deteriorating in front of our eyes, his pancytopenia was worsening like morning to after. Evening counts, the cytopenias were worsening. So we had no time to lose. On clinical grounds, we started treatment with IV methylprednisolone, and there was a dramatic improvement with that. But again, about day 3, he started deteriorating. Like we gave for 3 doses, we gave 500 milligrams because we hadn't completely excluded infections under antibiotic cover. We gave 500 milligrams methylprednisolone. After the 3rd dose, he started deteriorating again because, as I usually tell my trainees, steroids are not disease modifying, they just buy you time. So we bought all the time that we had, and then he started going down again. Then the problem was, what were we going to give? Because he was having fever and the cytopenias were very bad. So we had to start on something that would act quickly but would not suppress the bone marrow further. Actually speaking, had no other option. So we went ahead with cyclophosphamide. We gave IVIG, but there was no response. You would know that IVIG doesn't work that well for cerebral lupus. So we went ahead with cyclophosphamide. He was okay, but then day 2 after cyclophosphamide, just 48 hours later, he started having again high spiking fever. Only to see he was COVID positive, because at that time he had like nosocomial infection with COVID. There were many patients in the ward who were positive. This happened 2021. So then he was COVID positive, and then he was transferred to the COVID ward. He ended up with a bed sore, huge bed sore, because there was no nursing care virtually, and he was a patient who had to be tied to a bed because of neurolupus. So many complications later, like we managed to pull him through. So we gave the second dose of cyclophosphamide also while the patient was there in the ward, and then we discharged, and he's now on clinic follow-up, well on maintained on MMF. So the problem was we got the ANA only 2 weeks into this whole fiasco, because you know like what our immunodiagnostics are like. At that time, the ANA was only available as rapid as this, at least from our city. So we had to find the money, convince the family that you need to find the money to do it, and then they did it. And the report was available only 2 weeks later, after everything was finished, to say that it was highly positive and a nuclear homogeneous pattern, which was very highly suggestive of SLE. And also the complement C3, C4 levels, which were extremely low. He was consuming complements. So the diagnosis here was SLE with CNS involvement, but it was not an easy diagnosis. So basically we went taking a chance. We explained to the family, we can only do so much. We had covered with antibiotics, nothing is working. So we'll try this. He might die, he might survive, because without anything, he's going to die anyway. So luckily the parents consented, and we went ahead with treatment, and he survived. So the second case was a 37-year-old female from Handesa who was admitted to the National Hospital Kandy with fever for 2 weeks. And during the third week, she took a turn for the worse. So she admitted with fever for 2 weeks, and just after admission, only about 2 days after admission, she developed hemodynamic deterioration and severe pancytopenias. And this is the diagnosis. So if you might be able to tell the diagnosis looking at this is a bone marrow. So it was HLH. So hemophagocytic lymphocyte histiocytosis with septic shock was diagnosed, and the patient was treated in the ITU in Kandy. So she made a recovery and was discharged home. So she had been given dexamethasone along with antibiotics, and she recovered, and she was sent home. But 2 weeks later, readmitted there again with high fever, and again no focus could be found, just 2 weeks later. And the patient, this time she self-discharged like most of our patients, and she got admitted for Peradeniya for a second opinion. And again, the investigations were in favor of HLH. So this was a recurrent hemophagocytic lymphohistiocytosis, which was a bit strange. She reported a history of excessive hair loss and oral ulcers in the preceding month before the onset of the fever, but there were no other CTD symptoms. And you know, like when females come and complain of hair loss, that is a very difficult thing to say whether it is significant or not, because 90% of the females anyway have hair loss. So is this significant hair loss or not? And the other thing, she was having an acute illness, and we all know about telogen effluvium. During an acute illness, all the hair that you get are lost anyway. So is this that hair loss, or is this significant hair loss? Very difficult to say. And the oral ulcers that she had were actually not the typical palatal ulcers. They were mainly the buccal ulcers which she was complaining about. So we were not sure whether this was a CTD related something or not. But her ANA was positive, 1 in 320. The pattern was not homogeneous, but it was a nuclear pattern. Complement C3, C4. C4 we got done from Peradeniya, where they still do the occasional 1 or 2, but C3 she could not afford. So C4 was low, significantly low. It was only about, if I remember correctly, it was about 3, which was low. But the problem was her CRP was 100 and the procalcitonin was 5.6, which both say sepsis. So what to do was the problem, because she was already on antibiotics. B-side patients, Chamara knows this patient, so was already on antibiotics, but she was not responding. So still, based on the rest of the findings and due to this lack of response to any antibiotics, we just took the chance and started the patient on IV methylprednisolone while she was having a high PCT. But still, she remarkably improved biochemically as well as clinically. Very rapid improvement following the start of methylprednisolone. So, starting from that point, so the fever started going down, and the CRP also started improving, which was very strange. And anyway, after the 3 pulses of steroids, we took a chance and gave ahead and gave the first dose of cyclophosphamide. And last week I saw her. She completed the 6 doses of 2-weekly cyclophosphamide, and currently she's in remission. She still maintains remission on MMF. So what was the diagnosis was the problem? We don't know. So sometimes we can't really label. So what we have diagnosed at the moment is as undifferentiated connective tissue disease because all she had was the aphthous ulcers. We don't know the hair loss was significant or not, but she went into severe immune activation because macrophage activation syndrome is by far the most severe immune activation that you can get. It's kind of a cytokine storm, activates the natural killer cells to go and attack your own cells. So it's a severe immune response. So likely this is in the spectrum of SLE, but we can't really watch and wait until all the boxes are ticked. So we are managing with MMF at the moment. So like what is this HLH and macrophage activation syndrome? What's the difference? Virtually there's no difference. The only difference is the macrophage activation syndrome is HLH when it happens due to an autoimmune underlying CTD. We call that macrophage activation. But the immunopathology as well as the diagnostic criteria and everything is that of HLH. Right. So there are, like I have spoken to you about the mimics, like where can things go wrong in the diagnosis. So the challenges that we encounter are usually to do with immunodiagnostics as well as tropical infection diagnostics, both of which we don't have, unfortunately, very accessible. So the next thing is about the challenges with treatment. Now, with one case, I told you the challenges that we had with immunosuppression in the case of the 19-year-old boy with SLE. And this is the third case. This was a baby, which made matters even worse. He was only 3 years old and he was seen by myself in mid-2022, being referred from the pediatric ward for joint pains, fever, and leukocytosis. At that time, the diagnosis to me was pretty straightforward. It was a case of SOGIA, but given that this is a systemic onset juvenile idiopathic arthritis, SOGIA. So, but still, like in children, SOGIA is almost a diagnosis of exclusion. So you had to look for everything else. We did look, including the bone marrow, everything was done and negative. And he was diagnosed to have SOGIA and started on treatment with MTX and tapering steroids. Unfortunately, the mother never took the child back for rheumatology review. She came because it's going to be 2 clinics, rheumatology and pediatrics. So she never came back. And the next time I saw this patient was only a couple of months back. And that time, like he came, I'll tell you how he came. But in the meantime, what I realized was he has had at least 3 hospital admissions, all 3 times managed with IV steroids, for which he responded, and like the patient was sent home. So MTX with steroids. So unfortunately, he could never be completely taken off of steroids, which to me would have rung alarm bells because that means the disease is not under control. But this time, he came with fever, a very chesty cough, and shortness of breath, and the child was oxygen dependent by the time I saw him. And the chest X-ray showed widespread inflammatory infiltrates with extensive bronchopneumonia, even though they never test a culture positive, because by the time they come, they have been like backed with antibiotics by the GPs anyway. So none of the cultures came positive, but he was clinically as well as biochemically, this was infection. Like his inflammatory shadows on the chest X-ray were very bad, so that was infection. The problem was, now he initially showed a good response to antibiotics. So thinking this was infection, we didn't stop his immunosuppression. We just kept, we did not escalate. We kept it at that. Started the baby on antibiotics along with the microbiology opinion, and he responded initially. But the problem was after 3 days of fever free, again he was spiking fever and again becoming oxygen dependent, and the child was very ill. Even in between fever spikes, he was now becoming very ill, not active at all. So there now we were suspecting there was probably activation of SOGIA, but the CRP was very high. It was above 300. CRP was persistently above 300. And the procalcitonin was 7 and above 7. We did it twice from Candy. Both time it was above 7. Therein lies the problem. So now he did have activation of SOGIA, clinically speaking. Again, for activation, we had no other marker because this is one problem with systemic onset JIA, because it's an autoinflammatory disease. You don't get antibodies. It's mediated by your activation of the innate immune system. So no antibodies. And there are no other disease-specific markers because if you take ESR and CRP, both go up in infections. And the procalcitonin was also high, telling us, okay, there was probably sepsis going on. However, the disease was also very active. So it was a very, very difficult immunosuppression decision. And we started him on IV methylprednisolone, but despite that, he started deteriorating. And this time, the problem, our main worry was his cell counts were coming down to half every 24 hours. When he came in, his platelet count was above 800. But like over 24 hours, the platelet count fell to 400. Okay, still it's within normal, but the problem is when a patient like this starts dropping their cell counts that rapidly, the problem is macrophage activation syndrome. So that's what we were suspecting. Now his white cells were dropping, like he came in with about 30,000 white cell count. I think on admission it was 50,000 or something white cell count. It came down to 20,000 with antibiotics, and I was happy. Okay, with antibiotics, now the infection has started settling, and this was the systemic JIA causing the high white cell count. But now the problem was the next count, it came down to 14,000. It was like not expected to go down that rapidly, and it's now coming down. And that is when it's due to macrophage activation. So later, now given that he was not responding to anything, we started him on IV tocilizumab along simultaneously with IV immunoglobulins, with which he actually started responding, but the response was not rapid enough, and he was still oxygen dependent and very ill. And therefore, after 2 doses of IVIG, we had an MDT and decided we'll go ahead with plasmapheresis. And that's what we did. And with this combination, finally, after about 1 week of battling, he was out of the woods. So he was discharged successfully 2 weeks into this whole fiasco. However, it was an extremely difficult case. At one point, I had given up on the child. I did not think that he was going to survive. And I had even given warning shots to the parents. Okay, we are doing everything that we can. Most likely, we'll see some improvement. If he doesn't improve within 24 hours, I'm giving up. So to that level, I had to counsel the parents also to give the warning shots because we did not really expect him to survive. It was that bad. So this is another challenge that we face because infection triggers immune disease. It's not just in the causation, but flares. We see this very common in clinic patients, like they are in remission, very nicely doing with all the immunosuppressives. But the problem being they are on immunosuppressives. They are very prone to get infections. And the time that they get an infection, 2 weeks later, they get a flare of the inflammatory arthritis. So it's infection probably triggering the immune response. So here the diagnosis was that it is a community-acquired pneumonia, severe one, in an immunosuppressed patient, leading to a flare of Sogia culminating in macrophage activation syndrome. So we talked about the challenges with causation, disease mimics, with delay in diagnosis, and the difficulties with immunosuppression in patients due to tropical infections. And lastly, about what we can be doing beyond this, what is the way forward? The current problems with diagnostics are that they are unavailable most of the time and extremely costly, and the reports are not available in a timely manner, like sending an ANA and that being available 2 weeks later is not going to help with anything. And substandard laboratory techniques, like there are ANAs that are available. If you send outside, they'll give you the report within 24 hours. And they usually come back negative when the patient has hair loss, oral ulcers, and the malar rash, they come back negative. The problem being, even though if you see those reports now, the SR and the registrars know that I usually get mad when I see reports like this. I tell the HO to refund the patient and then send to the standard lab because they have to spend twice. This is why I'm very particular about this. Because if you take a substandard lab report, they do not tell you what was the technique that they used to do this. They'll just say whether the NA is positive or negative. That's all. And if you really go to the lab and find out, try to find out, because once our college did this, and what they're actually using is slide agglutination, particle agglutination, which is not used in any standard lab anywhere in the country, anywhere in the world, not let alone the country. Because once they did a study at MRI from samples that were known to be ANA positive from the immunofluorescence method, which they had at the time, because the ministry was pressurizing them to purchase this particle agglutination, which was much cheaper. And when they did the known samples, only 20% became positive with the slight agglutination. So it's that bad. So that low sensitivity. So do not rely on that. So that the problem is with the substandard laboratory techniques. So the cost is a huge problem. We once tried, Professor Champa and myself, we tried to see whether we are able to provide ANA at a lower cost if we find the expertise and everything. Unfortunately, we cannot go to a cost that is much lower than the available market price at the moment because the reagents are so costly. Now, at the moment, the ANA with the titer in the private sector is 9,000 is the lowest price for an immunofluorescence at a standard lab is 9,000. So if we go with with whatever we have, we still be able to charge the patient about 8,000 rupees, which is not really cost effective in like compared to all the costs that are involved in setting up the lab and running and everything. So these are the problems. So what we are going to do about this, we'll have to sit down and think really what are we going to do about immunodiagnostics. Because our pathology lab, our home pathologist Dr. Sakuntala was very helpful. So she did establish the complement C3, C4 levels because it's an ELISA that is run. But unfortunately, we can't even maintain that because even for that now the reagents are not available. C3 has been out for the last 8 months. And C4, they are doing only on the essential samples, only on consultant request they are doing because they have about this much of reagent left. That is the problem. So improving diagnostics in immunology. So I'm talking here about the immunology side. By tropical diseases side, we do need to improve the diagnostic because like the problems that we are facing with the disease mimics. Because at least if we can explore the infections, then we'll be left with whatever the immunological. So infections, and at least for the tropical infections, because we should be the experts in tropical medicine. We are the ones who see the infections. So we should be the experts rather than listening to the people talking from where they have seen like one dengue case over the last 1 year and they're talking to us about how to manage dengue. So we should be improving the diagnostics. Thank you.
Thank you very much, Chathurika, for this interesting presentation. And actually, you shared with us a lot of information that we didn't know very much, right? With the cases. So now the audience may be having questions to ask Chathurika.
Chathurika, Udiralapana here. Can you hear me?
Yes, sir, can hear.
All right. Yeah. Thank you very much for that very informative presentation. And I totally agree. This is rather than a question. This is just an opinion and suggestion. So I think I totally agree with you. Right, have to improve our immunodiagnostic thing because even when you are going to write a paper, sometimes we stuck. They will ask whether you have done this kind of innovation. So most of the time we have to say because of our poor resource setting, we couldn't do that. So sometimes they repeatedly asking why don't you do that kind of thing. I think as a faculty and I think of immunodiagnostic area and even the Champa and and if you can get together and try to develop the immunodiagnostic laboratory, I think that will be useful. Sometimes if you have a and submit to the university, sometime when some donors come, they can help you. So think about that also.
Yes, sir. Thank you, sir. We have actually been trying to work on that, but funds are very limited. It's been a sort of a challenge for the last 2 years. Since the time I came back, we have been on the talks about that, but we are trying. We try, sir.
So I think is sometime maybe other faculties, I don't know whether biochemistry or veterinary science faculty, whether they are also doing the similar kind of, and we can have one central laboratory for a university. No, that's something because when there are very expensive tests, we can't have lab in everywhere.
Yes.
So just see whether those kind of tests will be doing at science faculty and other with agriculture. I don't know. Just check that also, right?
Yes, sir.
Any other question?
Why did you consider autoimmune hepatitis?
So autoimmune hepatitis was also considered. That's why we did the imaging and everything. But then there were other features that did not fit in with it clinically because the severe cytopenias were not fitting in. And then going back in the history only, the parents realized, okay, there was probably hair loss before that. Because we also realized what was his healthy hair after we started treating him. Because initially I actually thought he had dyed his hair like coppery color hair, but only to see that that was the unhealthy hair caused by the SLE. So it was a very challenging case because then after starting on IV methylprednisolone, the father came with some clinic books and everything, only to see about 3 months back he had been diagnosed to have a cytopenia and been investigated at Chilau. Even though they were from Anuradhapura, because they were initially transferred to Anuradhapura, he came there with abdominal pain. And they thought at Tambuthegama that it was a pancreatitis and then sent to Anuradhapura. And Anuradhapura surgical board, they detected the cytopenia, and the surgeons are not very interested in the cytopenia. Once the abdominal pain settled, they sent him home. And once this like behavioral changes started happening, the parents again took him to a doctor who decided, saw the cytopenias, and given they lost faith in Anuradhapura, they went all the way to Chilla. And they asked to do a bone marrow, and bone marrow, because of the fear of bone marrow, they didn't want to do it. And thinking that we would blame them for not doing all this, they did not tell any of this. So this was also only 3 months. And after we started on methylprednisolone only, they said that. And the severe cytopenias also, they were taking us away from autoimmune encephalitis.
Chathurika, that in your first two slides, you showed that different hypotheses of the infection causing autoimmunity.
Yes, sir.
I mean, how those hypotheses they have arrived at based on actual just a mere hypothesis, so whether they have investigated etiology, right, and try to
These are
work it out.
actually research based. Like they were initially put down as hypothesis, but in different autoimmune diseases, they have shown the different mechanism acting. Particularly about molecular mimicry, the best example they give is the post-streptococcal glomerulonephritis, where they have like this M antigen, which is like it's there in the endocardium as well, and like the rheumatic fever happening and all that.
Yeah.
So, like there is research. Probably they originated as hypothesis, and then the researchers tested them in vitro and saw whether they're actually working. So actually, like in SLE, this epitope progression is one of the mechanisms that they have put forth to explain possible associations between infection and this.
When you talk about the infections, actually, the term is quite vague, right? The viral infection, something. Have the post-streptococcal glomerular infection also? They are the definitive pathogen.
Yes.
Like that, are there definitive pathogens so
It's
far?
been very widely investigated in rheumatological disease, but so far no single pathogen has been isolated. Because bacterial infections are thought to be important in particularly rheumatoid arthritis. Because as I told you, that rheumatoid is very common when the patient's living conditions are poor, rheumatoid becomes common and more severe.
Yeah.
So that's why they actually thought that it was initially related to bacterial pathogens, but then it could never be proven.
Right. Yeah, that's the thing actually. When you come to this medicine, right? Let's think about the cause and effect, right? So we see the effect as diseases, right? So we don't know the cause. We treat the effect actually, like rheumatological disease, arthritis.
Yeah.
We're just treating the effect.
Treating the effect, exactly.
Yeah, we don't find the cause. So, do they really recover?
Good questions. So actually, this is something that patients keep on asking me, because it is going to be lifelong treatment. What I can say is the current evidence says that they are not lifelong, but they are long term. That's a difference. It's like treating a patient who comes with a pulmonary embolism with warfarin. So is that going to be lifelong? Earlier we used to say yes, lifelong, for the rest of your life you had to take this. But if the patient came with a pulmonary embolism initially at the age of 35 and you start on warfarin, at that time, if you compare the risk versus benefit, it is justified. But at the age of 80, when the patient has already had a stroke, has imbalance, starts falling down, at that point, the risk versus benefit, it becomes more towards the risk. So you do not continue beyond that. So you take an individual decision to stop. So rheumatological diseases are also like that. You can never say that they are lifelong. You all would have seen enough patients with burnt out rheumatoid arthritis. They have the deformities are there, but no active disease. You ask the patient whether they have symptoms other than the symptoms caused by the inability to grasp something. They don't have anything. No early morning stiffness, nothing. If you look at the joints, the bony swelling is there, but no sign of thickening, no swelling. So this happens. But the problem is in which patient. Like if you take 100 patients and follow up, they say about 30 will develop burnt out disease later on. Like they will go into a drug-free remission. So which 30 is going to achieve this drug-free remission, we cannot predict. That is the problem. So, but in essence, in practice, what we see is if you start treating a patient within the first 3 months, the likelihood that they will achieve drug-free remission later on is higher. So that's why we encourage early treatment. When we were students, we learned that if you diagnose rheumatoid arthritis, if you suspect, treat for 6 months with NSAIDs. If they still have persistent symptoms, if there are erosions on the X-ray, you go ahead and start DMARDs. That's what we learned. Our Kuman Clark 6th edition, that's what the guideline that was given. But just 1 year later, that changed. 2011, there was a guideline from the ACI, combined guideline. They completely changed the way that we looked at arthritis, rheumatoid. But because now we say, if you can start treatment within the first 6 weeks after the start of the symptoms, that is the best. So it's very challenging because if you go through the classification criteria for rheumatoid arthritis, they say at least 6 weeks of symptoms. But rheumatologists are allowed to diagnose rheumatoid arthritis even within the first 3 weeks, because looking at the pattern of involvement, the symptoms that they say, the bloods and everything, as a whole, we can sometimes predict, okay, this patient might have persistent arthritis going beyond 6 weeks. So we don't wait. We start treatment then and there. So one can argue, okay, so we will be over-treating. We may be over-treating. The few percentage of patients who might have gone into a spontaneous remission, we may be treating. But that is only a few. That is what the research has shown. So there's a lot of interest in this early inflammatory arthritis. What the research has shown is the percentage that goes into a spontaneous remission when they have certain characteristics are actually a minimum. It's a minority. So it's still worth trying to treat them. So there has been a lot of interest in identifying these patients with different haplotypes and seeing if they are going to develop, those who are at risk of clinical rheumatoid arthritis, and then treating them. This is mainly in rheumatoid arthritis, and then treating them before they develop the disease. But then the problem is with epigenetics. Not everybody who has the gene are going to develop the disease. So we will be over-treating a massive number of people if we do that. So far that research is stagnating. So it hasn't progressed much, but it's been in the basket for about at least the last 7-8 years now. So studies are still going on about recognition and treating to prevent the occurrence of the disease is also under, as I said, under consideration. But so far it's about risk versus benefit. Do you want to risk the medication that you know has a lot of side effects to prevent something that you may never know is going to happen or not? It has come to that. So if you were the patient, would you be willing to take methotrexate to prevent rheumatoid arthritis, which might or might not happen in the next 10 years of time? I wouldn't.
Any more questions?
Actually, okay, we don't know. Is the real thing, because when we go for APLA, now we have the APLA just like the EULA, that is the Asia Pacific League Against Rheumatism. So when we go for the APLA sessions, what we see is APLA is also highly variable, even though it's the Asia Pacific region, because Australia is an APLA country, Singapore is an APLA country. So even when we try to write to APLA journal, so I tried writing one case where we had such challenges. It was such a difficult case where the patient came with pulmonary hemorrhages, and she was a vet surgeon, sir. So a vet surgeon coming with them for the first time with pulmonary hemorrhages, she was actually one patient who died. We could not do anything. Only to see later it was SLE with pulmonary hemorrhages. So what I wanted to say was making that diagnosis in resource poor, challenging settings. But when it went for reviews, they kept on asking, where is this investigation? Where is that investigation? And I kept on telling them, this is why I'm sending this to the APLA region, because I think this is applicable. Because we don't have those diagnoses. That is the problem. But then they don't accept. Because the problem is the journal is based in Singapore. And the editors and most of the board of reviewers are from Australia. So they do have. But we don't. So if we look at the discrepancy of the facilities, if we take just India, in certain provinces of India itself, the discrepancy is huge. There are patients who are suffering with not even paracetamol, when there are patients who are biologics over the counter, like that. It has come to that. So countries like Thailand, I would say, are perhaps much better off than us, perhaps given their facilities. But then again, if you move away from Bangkok, it's worse than even India. That's what some of my friends have said, because I had a friend who went for rehabilitation training in Thailand. So there's this huge rehab center, which is the biggest in South Asia. It's in Thailand. So he had gone there, and what he said was you will be surprised if you go about 30 miles away from Bangkok, you will be surprised as to what the sort of facilities are. So if we compare Colombo versus here, I would say there's no much difference because like when we talk about these diagnostics, when we try to implement in the government sector, what the government is saying is you have everything in the MRI. But practically speaking, the once you pass the Colombo city limits at Calania, that's as good as in Mars. We send 100 samples, only 5 will come back. That's also a call කරලා බැනලා ගෙන්න ගන්න ටික විතරයි. Otherwise, it's not going to come back. So that there's a extreme discrepancy, even within countries. So within the region, there is huge discrepancies. So probably countries like that have much better facilities. Even Hong Kong is APLA, so you can imagine Hong Kong and Japan are APLA.
Any question? Registrar, immunosuppression.